patient is a 45-year-old Caucasian female with chief complaint of stomach cramps and pain and constipation times 1 week. History of present illness. Patient states the pain is a constant, dull, low abdomen, cramps and pain that radiates to the lower back with constipation times 1 week. Patient's normal bowel habit is 1 BM every 3 days. She also has a chronic history of constipation, which she's noted since she was about 16 years old. She had a colonoscopy 1 year ago, which was negative. Review of systems. Patient denies nausea, vomiting, weight loss, fever, rectal bleeding, rectal hemorrhoids, vaginal discharge, any urinary symptoms such as frequency, hesitancy, or blood in the urine. She also denies any problems with ambulating, bending, or any numbness and tingling in legs and feet. Physical exam shows the EENT to be unremarkable, noting no adenopathy and no thyroid enlargement. Lungs are clear with vesicular sounds in all lobes. Heart is normal with S1, S2 sounds. The abdomen is soft, non-distended, but mildly tender in the low abdominal region on both sides. It is noted that on palpation that stool can be felt in the lower abdomen, but no masses are palpated. Bowel sounds are positive in all 4 quads, and patient reports passing gas or flatulence. On rectal exam, it is no hemorrhoids, no masses or fistulas are noted. Hemoccult is negative. Social history. This patient is a non-smoker, has approximately 1 to 2 alcoholic drinks per month. She lives with her husband, her adult daughter, and her granddaughter, her teen son. She works full-time at a desk job. Past medical history. She's a healthy female that is newly diagnosed with mild hypertension within the last month. Allergies to meds are none documented. Her only med is lisinopril, 10 milligrams daily, which she was placed on 1 month ago. My differential diagnosis for this patient, the first one would be chronic idiopathic constipation. For the first treatment plan would be lifestyle changes to encourage her to increase her fluid intake to 8 to 10 glasses a day, her fiber intake to 25 grams per day, cautioning her to do this on a slow, gradual basis due to gastric distress. Also to encourage her to drink, upon getting out of bed, to drink 8 ounces of warm water with the juice of 1 lemon, which will also help with GI motility. Medication for this patient with chronic idiopathic constipation would be Miralax. We've taken in 8 ounces of liquid daily, instructing her that no other medication should be taken 1 hour prior or 1 hour after this medication because it will hinder absorption. Also adding Colase, a stool softener, 100 milligrams daily. And also encouraging her in bowel training by giving herself about 15 to 20 minutes a day of uninterrupted time to allow for the bowel movement to happen and not to avoid the urge to go to the bathroom. Another consideration would be adverse drug reaction with the lisinopril. However, it is noted that less than 1% experience constipation and abdominal pains from this medication. The second differential diagnosis would be irritable bowel syndrome with constipation. treatment plan would be first to consider lifestyle changes, as with constipation. Once you've done that, to take at least a 6-month history of bowel habits, noting any pain or cramping with going to the bathroom and any palliative measures used to relieve constipation. Medications that could be added to this regimen would be anticholinergics, such as Bentil, which is 20 milligrams QID, or possibly Levocin, 1 to 2 tabs every 4 hours as needed, cautioning you should only take a maximum of 12 in 24 hours. Research has shown that adding tricyclic antidepressants will help with IBS symptoms. Placing her on Elavil, 75 milligrams daily, also letting her know that could increase. Antidepressants do cause slight constipation. One other drug that might be considered is Amitiza, which is also used for constipation and IBS symptoms. The last differential diagnosis for this patient would be diverticulosis. First, drawing lab work, CBC with diff, looking at the WBC for any type of infectious process going on. CMP, looking at electrolyte disturbance. CRP, looking for any chronic inflammation. And also to consider a TSH, looking for any kind of hypothyroidism, which could also decrease mobility of the GI tract. Again, first place treatment would be on lifestyle changes, increasing your fluids, increasing your fiber, adding Miralax Colace. Also, one thing that should add for all three is to also encourage mild exercise, such as walking. And also you may have to place these patients with diverticulosis on narcotic pain medication due to the pain and abdominal cramps. Also instructing them that narcotic pain medicines also increase constipation. Diagnostic tests for this diagnosis would be barium X-ray to look for any type of disturbances in the intestine. And the last would be to consider a gastroenterologist consult for possible update of the colonoscopy or other further tests for evaluation. And that is my recommendation and treatment plan for the patient with chronic constipation and abdominal pains for 1 week.